the Healthcare Supply Chain's Response to COVID-19, hosted by the AHRMM Learning Community. Hi, everyone. This is Mike Schiller, Senior Director of Supply Chain at AHRMM, and I will be moderating today's session. Just a quick note for those who may be unfamiliar, AHRMM is a national professional association dedicated to providing education, leadership, and advocacy for healthcare supply chain professionals. Throughout the COVID-19 pandemic, AHRMM is working closely with government agencies, healthcare leaders, and professional organizations, GPOs, manufacturers, and distributors to provide the most up-to-date information and resources. This open forum will allow all of us in the healthcare supply chain community to share innovative solutions and approaches being implemented across the healthcare field to combat COVID-19. We will be de-identifying and sharing these solutions from today's webinar with all of you. We are excited to welcome a diverse audience to today's call. As a note, all lines have been placed in a listen-only mode. We have summarized the questions you provided as a part of the registration process, and we will spend roughly 8 to 10 minutes on each of the 5 or 6 top questions that were asked. There are 2 ways for you to join the conversation today. First, you can raise your hand and verbally share your feedback. To raise your hand, open the participant module by clicking the person icon at the bottom of the screen. Once the module is open, click on the hand icon at the bottom right side of the screen to raise your hand. You will be prompted verbally before your line is unmuted, so please be prepared to speak at this time. After you have provided your feedback, lower your hand by clicking on the hand icon again. The second way to share is through the chat box, which can be found by clicking the chat bubble icon at the bottom of the screen. While we won't have time to hear from everyone today, so if you are unable to share verbally, please either share your solution into the chat box or feel free to email us at ahrmm.org, ahrmm@aha.org. So just a few housekeeping items before we start. Please be as concise as possible when responding to allow for the most number of solutions to be verbally presented. We've got a number of attendees that we're extremely excited to have, and we want to try and be able to hear from as many of those as possible. Please offer innovative approaches and solutions only. We ask that there are no sales-oriented conversations. And lastly, for this to be successful, please share within the context that this is truly a collaborative learning environment. And the goal of this webinar is to learn from one another, to come together at a time like this and learn from each other. So with that being said, let's move into our first question. The first question is, how are you managing spikes in supplies due to practice changes? And how are you conserving PPE? And we're talking not just PPE, masks and gloves and gowns, but we're also talking respirator and ventilator components. We're talking about test kits and swabs. We're talking about germicidal wipes and gels and cleaners. Beds, we're hearing beds are becoming an issue. IV tubing, extension tubing is becoming an issue as a number of organizations are moving their IV pumps out of the patient room to try and conserve. So what we'd like to hear from you is, how are you managing the spike in supplies? How are you conserving your PPE? So with that, Melissa, I'll turn it over to you to start opening up the phone lines.
All right, we don't have anyone with their hand raised, so just as a reminder to click the hand if you want to share. Tina, you had your hand raised at the beginning of the call. I'm not sure if you're wanting to share, so if you are, if you can lower your hand and re-raise it.
So are there any conservation practices that folks are employing?
We have Brent Petty. Brent, I'm about to unmute your microphone.
Hey, good morning, everyone. Obviously, I'm not on the provider side of the fence, so I can't lend direct feedback to the conserving of it. But I did hear this morning, and I'd be interested if anybody else has heard about it, is that they are testing the ultraviolet light decontamination on the N95 mask. If anyone else, and it seems to be positive, if anyone else from the provider side has heard that or is beginning trials on that or plan on using the ultraviolet light to re-sterilize N95 masks.
Do we have anybody who's going down that pathway? So from a conservation practice, how many are referencing the CDC site and optimizing strategies around N95 masks or gowns, gloves? The FDA also has some information as well around optimizing supply. So really would love to hear from you. Again, the whole purpose here is to learn from one another. So I have to imagine that with the number of attendees that we've got some really good conservation practices taking place. So please share those. Do we have anybody raising their hand, Melissa? Hello? Did I lose you guys?
Oh, sorry about that. Karen has a comment that she wants to add. Karen, do you want to add your comment? I have you unmuted.
Yes. Am I unmuted now?
Yes.
Can you hear me?
Yes.
Okay. You can hear me?
Yes.
Yep.
Or am I talking to myself? No. Okay, good. I did hear yesterday that there's a new actual research paper, and I could find out, I'll get a link to it, about work that's being done to take the N95s and to sterilize them with bleach for reuse. And there is some clinical data from a health system in the Northeast. And I think they put it out, even though it's going to a peer-reviewed journal, they put it out on a public health website, I believe, that makes it available to people. So I can share that with AHRMM.
That'd be wonderful, Karen. Thank you. I do know that NIOSH is going to be coming out with some guidelines around how to re-sterilize various masks in use. We haven't seen those yet, but we're expecting those to come out any day. So as soon as those come out, we will be listing those on our AHRMM COVID-19 website. So again, let me just emphasize, gang, that this isn't the intent here is not for me to talk through these. The intent really is to learn from one another. So please raise your hand and share what you guys are doing around the area of conservation of supplies, or if you're reusing your masks, surgical masks, ear loop masks, N95s, the NIOSH general use respirator masks, any practices around reuse or other conservation practices. Again, I'd mentioned some hospitals are, from a conservation perspective, are actually bringing their IV pumps out into the hallways and utilizing extension tubing to the patients. This will reduce the number of gown and glove and mask changes that are taking place currently. So any other practices out there, please share.
We have Victor Suarez, and he says that he has some practices that he can share. So Victor, I'm unmuting your line.
Wonderful. Hey, hello everybody. Can you hear me?
Yeah.
Sure can. Thanks, Victor.
Hey, I'm the logistician from Regional Health Command Atlantic. We are an Army organization, and we work with the Defense Health Agency. And in our region, we have about 14 medical systems throughout the Northeast, from all the way from New York State all the way down to Puerto Rico. And a couple things that I'd like to just say up front, which has been great with AHRMM, is you pushing out messages to members that has been very useful to share across the supply chain within the military system. And so a couple things that what I'd like to highlight that we were able to do with this is we closely monitor our PPE across our systems, and we report on what we call like a daily log stat of all our systems PPE status of all the top 5 products. And we also, based on what we did many years ago, was the Health Affairs and the Defense Department back in 2006 established a requirement for a pandemic influenza PPE assemblage that had to be stationed at every one of our medical treatment facilities for worst case scenarios. So this is above and beyond a separate assemblage on pallets, if you will, that would be different from your daily rotational stock. And that was an investment that was made to sustain that for the last 14 years. And what we found was in this constrained supply chain, that was very, very useful for about 10 of our sites in the last 2 weeks to dip into this reserve stock of PPE. And what we're doing is we pretty much have a daily communication with these 14 systems to cross-level and rebalance PPE where it's most needed based on a couple of things. One, based on their patient load and requirements, the installations upon which these health systems are located have varying levels of what we call health protection status. And so that requires more consumption of PPE, like at the gates and access points, not only to the bases that these hospitals are on, but also entry into the medical treatment facility itself. What we do then is we with a team of us, we rebalance where there's needs, and we monitor PPE levels, not only on the needs of that facility, but we also are starting to now look at heat maps and looking at the clinical epidemiology, tracking the disease burden. So obviously right now in the Northeast, the New York area is our biggest concern. We have a small hospital at West Point, New York, right where the academy is. And we're currently doing a bed expansion capability there right now. So we've started to migrate and surge more PPE and other critical supplies to that area because we've gotten reports from the Hudson Valley Mutual Aid Society of about 9 different hospitals that are basically partners in patient care. They believe they're going to be overwhelmed with their patient capacity for ICU beds and isolation rooms in about 2 weeks. So we are basically expanding that capability at the West Point Hospital to take on more advanced type ICU type patients. We've actually got about now 14 ventilators going that way, and we're sourcing additional providers from throughout the network and even drawing up from the reserves to fill critical positions in that particular facility. So not only do we then have a daily kind of assessment of PPE and we redistribute, thanks to AHRMM, what we've done is we've immediately instituted across the Defense Department the use of expired but serviceable PPE that we had on hand. And we found that was very helpful, and that really came from the AHRMM push of the CDC information and guidance about, the serviceability of PPE was probably the most important thing right now versus expiry for a med-surg product. And so we had all our sites basically inspect all their on-hand expired PPE for that. One of the most recent things we're doing is we found a lot of expired hand sanitizers. And so what we're doing there is we actually have one of our hospitals trying to develop a test protocol to test efficacy of expired hand sanitizer based on ASTM standards that the FDA put out about 4 or 5 days ago when they put out their standards to industry for non-traditional manufacturers like distilleries and brewery companies and chemical companies that wanted to get in the business of hand sanitizers. What we did was we looked at those specs, and we have one of our clinical labs at Fort Benning, Georgia at Martin Army, who's developing a quick test method to test, like, if you will, on a petri dish or a plate, if the 3-year-old hand sanitizer is still effective and still has its active ingredient in the right quantities to kill the virus and the bacteria. And once we solidify that test method, we're going to try to validate it with another lab we have up in with the Institute for Chemical Defense, or one of the other labs we have in the Army. And if that's good, then we're going to share that with the rest of our facilities where they have expired hand sanitizer that's sometimes 3 or 4 years old. So as another way to kind of reassure the staff, if we're going to hand you something with an expiry date, that we've tested that lot sample with a statistical significance, so you have confidence that it's still effective. But we've also said to the hospital directors and commanders, look, it's your call. This is an outbreak situation, an emergency has been declared, and if your risk assessment is that issuing out 5-year-old or 3-year-old expired hand sanitizer outweighs the risk of having nothing as an alternative, we're going to continue. We're going to leave that with that hospital director, hospital commander, to make that call to issue it out to staff, with the caveat that we're doing some testing to validate the efficacy. So that was another practice that we're currently doing right now in the U.S. Army, and we're going to try to share that test method across the board. And you see some other things that I would say that we've done to kind of preserve PPE is it's really a learning curve. And one of the things we found was when we were asked to provide some limited PPE to non-medical people to do screenings of folks as they entered the gates of our installations, there was a lot of waste. There was some instances where they were, where we were doing temperature probe checks of people entering into buildings, and we saw people were changing gloves every single time they ran a tympanic thermometer over somebody's head. And so what we had our infection control teams and our clinicians say was, look, if you didn't actually touch the patient, you could probably continue to keep your gloves on because you're just running the probe over the person's head. And so, instead of using probes, if we run out of probes, we can then use alcohol swabs and basically sterilize the probes after every change. In some sites, we're using the IR thermoscan thermometers. One of the downsides with that, and we're still getting preliminary information, is whether or not those IR thermoscans are effective in the cold weather. So that's one of the issues we have in the Northeast, whether or not they're accurate when it's 30 degrees outside up in New York, to effectively get a temperature. So I'm open to any other questions, but we had a couple different practices that various Defense Department and medical treatment facilities and planners and logisticians do, and we have a daily sync every day, and we share practices across our entire enterprise globally. And I'll pause there for any questions. Over.
Victor, thank you so much. A lot of great work going on there. Real quickly, I don't want to take away from other questions. You mentioned ESPM standards for the efficacy of the expired hand sanitizer. Did I get that right?
Yeah, ASTM.
ASTM.
Yeah,
okay.
ASTM standards with the CFR. If you look at the most recent temporary policy that the FDA's put out about non-traditional business being compounders of sanitizer, all the specs are in that document that is hung on the FDA website for that new policy that came out on the 20th of March.
Wonderful. All right, we'll look at that and we'll get that out and make it available to the rest of the members. Thanks, Victor. Questions, responses, other stories to share that build upon what Victor has shared with us? Melissa, do we have anyone raising their hand?
We do not. So do you want to move to the next question?
Yep. Let's go ahead and do that. Victor, again, thank you so much for that great information. A lot of really good stuff there. So let's move. I'm not sure how many manufacturers we have on the line or distributors that we have on the line, but any information that you can share around allocations that you currently have in place and any visibility upstream into the supply chain that you can provide from products becoming available. I've heard that Manufacturing is starting to come back online in China. And I think the middle of March, there was a shipment of PPE that left China and is on its way here. I've also heard of other organizations hiring flights to go to China to air flight or airlift product back here, as opposed to shipping it via carrier over the sea, just to expedite the product coming back into the U.S. So any suppliers or distributors have any insights they'd like to share as to visibility, allocation strategies, supply availability? We'd love to hear some information around that if you've got something to share.
All right, it looks like we have Nancy Anderson. So Nancy, I'm going to unmute your line.
Thank you. I just wanted to make sure, Mike, that the rest of the group on this call, and they may be way ahead of me, but there's a new product coming out called the Exchange by a company called Resolink. And what the goal of the Exchange is, it's a technology product to help hospitals identify what products they have to share and what products they need from other hospitals in their region. And I can send you the link. That product's going to be launched free to the public, beginning with the rollout on April 5th. And it just seems to me that it's something we should all explore as a good way for us to take advantage of sharing opportunities when they exist. So again, I'll send you that link so that you have that information to share with our members.
And that's great. Thanks, Nancy. And you know, that gets a little bit, I think, to what Victor had shared, where they're rebalancing across their hospitals, right? Looking at PPE levels and patient levels and rebalancing PPE based on those needs. And so it sounds like the Exchange will act as a bit of a opportunity to rebalance supplies across hospitals. So that's great. I think we've listed something on our site, but please share that with us, Nancy. I'd appreciate that.
All right, we have Angie Haggard on the line. Angie, I'm unmuting your line.
Hello, good morning. Thank you. I don't know if others have heard about this or not. It was just recently released in the news, and I can share the links on the website, but there were face shields that were developed by Georgia Tech students recently. And the purpose of those face shields is to extend the life of PPE supplies. And they have also released the production criteria so they can be produced by any 3D printer. So that way local resources in the community can utilize them as well. But they're in essence intended to extend the life of PPE. And they are not FDA approved, so that's one note. But if it is helpful, I think sharing the links for these, I just wanted to share that information.
That's great. Yeah, thank you so much. I've read a couple of different places where organizations are sharing the files, right, the 3D print files, so that folks can download those, and if they've got the 3D print capability, to go ahead and begin to make some of these PPE supplies. Face shields are one of those, and there's some others that are out there. So it's really interesting to see the use of technology, right? We've talked about 3D printing in healthcare. You heard some examples of the use of 3D around implants and some other modeling, but you know, here it is in action in the midst of the COVID-19 pandemic, where it's actually being put to use. So anybody else? That's a great question I'd like to pose to the audience. Anybody doing any 3D printing or partnering with an organization that will 3D print PPE supplies for you? Anybody out there got a story to tell around utilizing 3D printing?
I'm not sure if this person does, but Sheila Jarrett had her hand raised. So Sheila, I'm going to mute your line now.
Good morning. I do not have anything on the 3D printing. Actually raised my hand before that question was asked. I'll just share real quickly. One thing we're doing, we are getting so many emails from companies saying they have available product, as I'm sure everyone is seeing that. We have facilities nationwide with our company. I work for the corporate office. So our team is currently trying to vet and review all of these emails that come through, all of these companies that are coming through. So as we vet them, we're putting do not use, or, making a note of the ones we have success with. We did notice on the RM website yesterday that I believe BAMCO was one of the ones that's on our list, that we just haven't had enough time to review that one. So, if I can make a suggestion, if anyone, maybe we could use RM as that resource, as we have positive communications, positive, orders, positive communications, and luck with these vendors. Maybe we could communicate that up. If we all do that, we would spend less time vetting and possibly find products that are out there. We're seeing a lot of these, as we have discussions, they are saying that there's product being released from China, from Shanghai, Malaysia. I think we had one yesterday that said they were getting their product from Turkey. So just to throw that out there.
You know what? That's great. And let me just let the group know here. So AHRMM is working and collaborating with GHX and expertise and processes that are being leveraged through their VendorMate solution. So VendorMate has a platform that they make available to hospitals to conduct background checks on vendors they are currently vetting. So AHRMM has been the clearinghouse right now for, I can't tell you how many, hundreds of emails from suppliers that have access to PPE. And so those are coming through AHA, they're coming through our member services, they're coming to AHRMM, and I'm acting as the kind of the hub and spoke here. So they're all coming to me. I'm working with GHX VendorMate solution. We're conducting a fraud abuse control information system level 1M search, and I'm not going to go into all of the gory details. Long story short, we are vetting vendors, and the ones that come back low risk, where we've been able to validate a business license, been able to validate their tax ID, they have no active, previous, or current active sanctions or previous sanctions going, and we've been able to view an Equifax report. If they pass all four of those criteria, we are hosting those on our website, and the page is going to be updated daily, because I'm sending literally 20, 30 vendors a day. And I just want to give a shout out to GHX and VendorMate for their partnership in this. It's been just tremendous help and extremely valuable. So we've got, I think, about 11, maybe 12 vendors right now that we vetted that are low risk. AHRMM is not endorsing the companies, AHRMM is not endorsing the products, and we strongly recommend that hospitals and organizations conduct their own vetting and apply and adhere to their own vendor review and approval policies and procedures. We're basically saying, hey, look, no red flags came through on this pretty extensive fastest level 1M search that we've conducted. We feel comfortable putting them out there. So want to let you guys know that, and if you've got some, I forget the speaker's name, but feel free to reach out to us at arm@aha.org with the information you have, and we can go ahead and combine it. Maybe we can collaborate again and just make this available. And I'm working with other folks across the industry. HIDA and SMI are two to mention, where we're sharing this list. The goal here is to get this out to as many eyeballs as possible, and we're also exploring the opportunity of creating a platform or an environment where the vendors who have been vetted and approved, right, the ones that we're sharing, are allowed into this environment, and then opening it up to distributors and hospitals to go ahead, and if they want to connect, great. It's just a meeting platform, if you will, to allow these folks who have supplies to meet and connect with the folks who need the supplies. So apologize for the bit of the AHRMM commercial, but I think it's really helpful. If you've got vendors that you want us to take a look at, feel free to send them to us. Any other questions? Any other hands raised, Melissa?
Yeah, we have a bunch of people who you strike a chord, I think, with a few of them. So I'm trying to go in order for you guys. So I think the first one I have is Kevin Strong. So Kevin, I'm unmuting your line now.
Thank you. The FDA actually just released a list of vetted suppliers for NIOSH-approved disposable filtering face masks. So I sent the link in the chat there, so you can maybe get that up on the ARM. It's a spreadsheet. It has several different vendors in there and all the FFR approvals associated with it. So a good resource to have. So thank you.
That's wonderful. Thank you very much. And just a quick reminder to utilize the chat if there's information you want to share via the chat, links you want to share. That at the end of the day, we're going to marry the chat information with the questions and the folks who have shared verbally, and that's what we'll go ahead and share once this is all wrapped up and done. We want to get that out to people as a resource. So there were some other questions you said, Melissa?
Yes, I'm going to, the next one I have is Tim Brown. So Tim, I'm unmuting your line now.
Thanks. This is Tim Brown from ECRI, and I just wanted to let you know that we would be happy to help contribute to the vetting of these new manufacturers that are entering into this space. We are getting requests from thousands of providers across the U.S. With seeking guidance on some of these new vendors, and we've been doing that with our U.S. office as well as our Malaysian office as well. So we'd be happy to collaborate with AHRMM and others on that effort.
Oh, that'd be great. Yeah, let's maybe you can share your information, Tim, offline, and you and I can connect.
Okay, and our next person who raised their hand, I have Kathy Cohn. Kathy, I'm unmuting your line now.
Hi, good morning. I'm with Techway Services, and we actually are a distributor helping hospitals. I was just going to go back to the question a few minutes ago. What we have observed is the hand sanitizers. I'll start with that. From China, they want to send over high volume, and we're talking 14, 20,000 units, and and it's obviously going across on a ship based on the alcohol content. But talking to hospitals, I think there's only 2 that we've supplied 2 containers of those 2, but everyone else has such a low quantity amount that they can't take that large volume. And also, it's a 30 to 45 day wait, and everybody wants something on hand. And the problem is most of this product is being manufactured, and Europe is ahead of us. And that's where a lot of the product is going. Just today, we have somebody that's actually in China, and they have siblings of theirs in China actually going to the manufacturers direct to see if they can really produce, because there's a lot of folks, if you get FDA certification or their certification, they want to verify that, because some are taking their certification and maybe utilizing it in other factories. So they want to make sure it's authentic. We can get masks and gowns. What's happening now, it can go in the air. Some of the flights are not there. A lot of stuff's coming in FedEx. They're telling us 7 to 10 days to get in KN95 masks. What we've also talking to the government really now wants made in USA. And so some of the stuff coming from China, if it says made in China, they won't take. But hospitals, they don't care, as far as if it has that certification or not. But those are just some observations. And I'm thinking, just speaking out loud, there's so many hospitals we've talked to across the nation, and all have the minimum quantities. If somebody can do kind of a consortium for the buying power, since a lot of manufacturers have a minimum of 100,000 units. It's just an idea that we want to come up with, how to supply all the product to all these individual hospitals with low quantities.
Yeah, and you raise a real good point there. Some of these vendors that are, coming forward and saying, hey, we've got access to supplies, they have minimum order quantities that a hospital is never going to meet, 10,000, 20,000, 100,000 units. And some of their payment terms are payment upon delivery. And so it really doesn't work well for a hospital, right? You're not going to pay on delivery. You're not going to buy 100,000 units of anything in one fell swoop, which again is why we're hoping to, Tim, maybe we can explore this and others if you're interested, how do we create this dance floor, if you will, where we allow the vetted vendors in, and then we have distributors who might be able to acquire those minimum or meet those minimum order quantities, and hospitals for the suppliers who do not have minimum order quantity requirements, right? And so what's that dance floor look like? Where do we create that dance floor to bring these folks together? So great points. Thank you for sharing. Melissa, other questions?
I think Sheila, you raised your hand again. Sheila, do you have something to share now? I'm unmuting your line.
Hey, I just to follow up with the information that we have, I do have a huge document that I would like to share with you, just so you could compare the vendors that you're already currently vetting. So is there a specific, if you could share after the call, a specific email or place that we need to put that on the AHRMM website, however we need to handle that? Could you share that with me?
Melissa, do we want that going to the AHRMM, just the AHRMM inbox?
Yeah, I think if you just send it to the AHRMM inbox, AHRMM@AHA.org, we have that email is staffed regularly, and it'll get to the right person.
Okay, thank you.
Thank you.
Yeah, great. Thank you very much. Other questions, Melissa?
Yeah, we just had 2 people raise their hands. I'm sorry, I don't know what order they came in. Richard Miller, I'm going to mute your line first.
Hi, good morning. Referencing your thoughts on the supply channel and vetting process, one of the things our organization is exploring right now is a clearinghouse for all manufacturers tied to PPE and putting that into an inventory management system and allocating it through a national distribution, almost like a prescription-based request form for the bill of ladings, so we can break bulk product and get it to the proper sources of need, whether it's a pallet at one hospital or half a container at another distribution center. It would also allow us to put some security on the vetting process to make sure that everything meets the right standards and NIOSH stamps and ASTM ratings. We just see a disparity in all the distribution. There's excess distribution in one part of the country and a lack of it. So we're looking at major distribution channels through 5 of the industry, trucking industries that have familiarity with this massive inventory movement, like the drugstore infrastructure or Home Depots or Staples of the world, and minimizing the handling, but still allowing smaller margins to control the price gouging that's happening in some of the areas, and kind of put an allocation. But building this vetting process and a secure site, giving people access to it, I think would take a cooperative effort to put that together on relatively few number of products that are required. That way we can have an understanding of what's available globally to be shipped, where it's coming in, when it's coming in, and distribute it properly according to need as quick as possible.
Thank you. Yeah, and just a quick comment to that. Thank you for sharing that. If there are these coalitions or other opportunities that organizations have come together and are offering whatever it is, services at no cost for the interim period right now during the COVID-19 pandemic, we do have a section in our daily update and on our COVID-19 webpage that is highlighting these coalitions, these companies that are offering application or other services at no cost, right? So if there is a coalition that already exists, similar to what was just discussed, please make us aware of it, because our AHRMM's not going to be able to take the lead on everything, right? And again, the whole goal here from a learning community perspective is we all learn from one another. And if somebody else has something already up and running that would be a benefit for others to know about, please make us aware of that so we can act as a clearinghouse, if you will, for those resources and information and making that available to the healthcare supply chain professional and the broader healthcare field. So you said there was another question, Melissa?
Yeah, we have one more from Sally Featherston. Apologize if I pronounce anyone's name wrong. Okay, Sally, your line is unmuted. Sally? All right, maybe.
Are you on mute, Sally?
All right, maybe we lost her. All right, do you want to move on to the next question? Just one housekeeping. If you have raised your hand before, click on that raise hand icon to lower your hand so that if you do want to share additional feedback, oh, no. All right, go ahead, Mike.
Thanks a lot, Melissa. So something that's been that has come up in the last couple of days is the use of a single ventilator to treat multiple patients. Curious to see if others out there are beginning to explore this, or if others out there, if their healthcare organization has implemented this. Obviously, there is a supply component to this with the tubing and the T connectors and other the ventilator components. But it is something that seems to be gaining some momentum. There's an abstract that I think will be coming out, if I'm not mistaken. The days all blur together, so forgive me, but I think I've got an abstract that'll be coming out in one of our updates here around an organization that did some testing on a single ventilator to 4 patients. So would love to hear if anybody's doing this or if there are any clinicians in the audience today. Any clinical perspectives on a single ventilator with multiple patients that you're seeing in place? Anything out there that you guys can share?
No comments yet.
Okay.
Oh, I think we have Karen Conway again. Karen, I'm unmuting your line.
All right, just very quickly, I'm going to share an excerpt from an email I received from a good friend of mine who's a pediatric pulmonologist. He was not aware of the technology. I think it was developed by a emergency medicine physician in Detroit. His concern was the impact on stress levels of the personnel. So just something we should be considering if we are able to utilize this fairly ingenious approach that ER physician came up with. And I'll just post it in the chat.
So stress, maybe you can elaborate just a little bit further, Karen, on the stress levels. Is the single vent multiple patients increasing stress levels or decreasing stress levels, or am I not connecting the dots correctly here?
This was from a friend of mine who is a pulmonologist, and he was just saying the healthcare worker, it adds additional work. He was just concerned. It's just one perspective, but I think it's important for us to be thinking about these innovative solutions. At the same time, we must be thinking about the impacts and how we're communicating and introducing these kinds of things in collaboration with clinicians.
Great. Thanks, Karen. Any other examples of organizations engaging in this practice of using a single ventilator on multiple patients? Any lessons learned?
We have Bill McGarry. Bill, I'm unmuting your line.
Hi, thank you. So historically, I have a background as a respiratory therapist, and I've seen the studies and I've seen the YouTube videos, and certainly people have to do what they need to do in times like this. However, when you hook up a ventilator to 2, 3, 4 different patients, the gas from that ventilator will always go down the path of least resistance. So if you think about 2 balloons, right, that are hooked up to a Y, if one of the balloons is in a bottle and the other balloon's outside of the bottle, when you blow, all of that air is just by physics, simple physics, is going to go to the area where there's less resistance, and that's the issue. Unless you have 2 to 4 patients with the exact same lung dynamics, it is not going to ventilate those patients equally. Can it be done? Probably. In a pinch, is it better than nothing? Maybe.
Mm-hmm. Great information, great perspective. Thank you so much for that. Appreciate you sharing that. Any other insights or perspectives?
We have Joan Melendez. Joan, I'm unmuting your line. Joan, you're unmuted. You might be muted on your end. Oh, okay. Well, Joan? Okay, maybe not.
And anybody else? Any other raised hands, Melissa, on this topic?
We do not have any additional hands raised.
Okay. So I want to pose another question to the manufacturer, supplier, distributors in the audience. Any concerns? I'm hearing some conversations around, of course, we all know the shortage of supplies, and we know that production is ramping up again and coming back online in China. We are seeing a production of N95s here in the U.S. as well to try and meet the global demand, certainly the U.S. demand. But there's discussion around raw materials. Are you hearing any conversations, any rumblings around or concerns with access to the raw materials? At what point, if at all, does this become a concern where we start to run into raw material constraints to even make the products? So just wondering if you're hearing anything or you've got any insights that you can share. Again, this is for our manufacturer and supplier distributor partners in the audience. And maybe it's not an issue right now, but again, there's been a couple of conversations that I've been involved in where the topic has come up.
We don't have
raised
any.
Hands, Melissa?
We do not.
No raised hands. Okay. All right. The next question.
It looks. Oh. I do have. Looks like Nancy Anderson. So Nancy, your line is unmuted.
Thank you. Yeah, I wanted to share, and it's not necessarily constructive news, but at least news that suppliers are concerned now, and I'm sure you all probably are aware of this, that there are some raw materials manufacturers who manufacture the raw materials for a whole series of companies that make the end product. And so there might be a single raw material source for multiple end product manufacturers. And so the end product manufacturers are really looking down their pipeline to see what those raw material suppliers look like, how their supply is going, whether they're coming back online, because the funnel narrows as you get back further in the supply chain for some of these products. Mm-hmm. So it's something that manufacturers are working on today, are concerned about, and are beginning to address in any way they can.
Thank you, Nancy. Yeah, that's exactly what we're hearing. So something to at least we can keep our eyes open on it from an AHRMM level. And Nancy, I know you will with the audience that you guys have there at SMI. And we'll certainly keep the membership in the healthcare field informed if anything should develop along this line. Hopefully not, right? We're fingers crossed, hopefully not. Melissa, any other raised hands?
Yep. Yes, we have John Blackcutter. So John, I'm unmuting your line.
Okay, thanks, Melissa. Yeah, I'm with Cook Medical, and so I don't have a whole lot of different information, I think, to offer than what Nancy did. I do know that when we've got those critical products, and for our case, it's usually our difficult airway products within our critical care space, and such that we know we're seeing certainly a large amount of an increase in orders in that sense for our existing customers, and then as we're looking at expanding that beyond that to all different parts of the globe and where we know we need to provide. We've not seen, as it comes to the raw materials, what I understand is that we've not seen any kind of a shortage in that sense. We are being very conscious of how, from a manufacturing perspective, that we're as I'm sure a lot of our other manufacturers are doing, shifting those manufacturing resources around to focus on these types of products, and then we put other shifts in place and things. So that demand is going up. I think that's something that we monitor very closely with our internal supply chain teams and how that's coming through. But I think all manufacturers right now are keeping a very keen eye on that, but we've not seen anything that I think would lead to any kind of a criticality in that sense. But it's certainly one of those things to keep an eye on.
Great. Thank you for sharing that information. Other raised hands, Melissa?
I think Tim, Tim, you raised your hand again. So Tim, I'm unmuting your line. Tim Brown.
Thank you. I'm kind of jumping around here. I apologize, but just going back to the ventilator issue, seeking guidance in that area, I just reached out to my colleagues, and we did a lab tour this week on N95 masks and the reuse of those, and we are doing one on ventilators next week. So I just wanted to let everybody know that ECRI would be a resource there as well. We'd be happy to share information with AHRMM, but we're doing tours in our labs of ventilators next week.
That's great, Tim. Thank you. And just for the audience, you know, we've formed a number of collaborative relationships here over the years, and certainly during COVID-19, we're coming together. And so AHRMM is working with ECRI, we're working with HIDA, we're working with SMI, we're working with ISM, the Institute for Supply Management. We're also working, as I had mentioned, with GHX and VendorMate. So we've got a lot of cross-community sharing, if you will, where our links to the AHRMM COVID-19 site resides on their web pages, and vice versa. We're hosting links to their website. So again, really trying to cross-pollinate and get the information out to as many eyeballs as possible. Any other raised hands, Melissa?
We do not have any other raised hands at this time.
Okay. So another question here. Let's jump to this. Have any of the organizations, hospitals, worked with their local or state emergency management agencies to access strategic stockpiles? Has anybody gone down that path? And if you have, what's that process look like? Maybe you can share that, because I do know that we're hearing quite a bit about people looking to access either state or national strategic stockpiles, and you know, they just wondering if anybody has gone down that path. Any examples or processes that you can share with us?
We have Karen again. So Karen, I'm unmuting your line.
And I simply, for purposes of being concise, there's a good discussion in the chat already on this. Mike, I know you're leading this, so you probably haven't had a chance to read it. I sent a link to an article that explains a lot and how it runs and what the experience has been in some states. And I see some other contributions from some other participants about their on-the-ground experience.
Excellent. Very good. Very good. Thank you, Karen. Any other raised hands, Melissa?
Yes, I have one. Let me just find Debbie Schmidt. All right, Debbie, I'm unmuting your line.
This is Debbie Schmidt from Carl Hospital in Urbana, Illinois. And we,
hi, Debbie.
Hi, actually, our hospital has the emergency preparedness for our region, and so there's pods throughout Illinois, and each of those pods has supplies. And we have reached out to them to utilize some of those supplies. So for us, it's been pretty easy because it's people we work with all the time. But it is, it's been a little difficult for them because they are being very cautious because, you know, they have like 13 hospitals that they have to take care of. They can't just take care of us. So while it's been effective for us primarily with the N95s and some isolation gowns, we haven't taken their whole stock, but it is an option.
Great. Thank you very much. So we've got a couple of minutes left. So let me do this here with the few minutes that we've got remaining. I want to ask one more question. Well, I guess I should see if we've got any more raised hands first.
No, but there's some nice discussion going on in the chat, so we'll be summarizing that and sending that out to everyone.
Excellent, excellent. And so that's really the approach. I want to pose this question and ask for the audience to just go ahead and enter your information in the chat box. The question revolves around how are you calculating burn rates for supplies, right? Not just PPE, but burn rates, right? We're running short on a number of other supplies that fall outside the realm of PPE. So how are you forecasting, or I'm sorry, how are you calculating your burn rate is the first question. Second question is, do you have any forecasting tools that you are using to try and forecast what supplies you might be running out of next based on your on-hand inventory, again, visibility upstream, and patient census? So those two questions, again, calculating your burn rate, and how are you forecasting products that you potentially could be running low or running out of? So if you can put those responses in the chat, that would be great. And Melissa, do we have the ability to keep the chat open for a few minutes after 10 o'clock just to allow folks to finish typing their responses?
Yes, we can do that. I do have one person who wasn't able to speak earlier. If you don't mind, I'm going to unmute her line.
Please.
To,
Absolutely, thank you.
Have her question it. So Joan, I'm unmuting your line now.
I think this is working
Joan?
now. Good morning, everyone.
Yes.
Good. Hey, Mike, just wanted to mention to everybody, and I put it in our chat, that we are offering our scanning solution for inventory purposes to all hospitals for free. So this will enable them to quickly just scan any manufacturer barcode to do their inventory. They don't have to have anything pre-built. We're also working with 3 other companies, Kermit and Track My Recall, in addition to Resolink, in trying to strengthen our website that we created called hospitalprepare.org. So thank you, everyone here on the call, for doing what you do.
Thank you so much, Joan. Okay, so we've got just about 2 minutes left. I want to pose another question and just ask folks to go ahead and chime in on the chat, just for the sake of time. And then I've got one more question that I'd like to pose. Community collaboration. One thing that really encourages me throughout this whole pandemic is how hospitals and communities are coming together. Private industry is coming together. Everybody is stepping up. And you've got the 100 million mask initiative that Providence Hospital out in Washington started. And the community was sewing masks furiously, and actually they met that mark, which is incredible. Or the Million Mask initiative that Providence had. In any event, examples of community collaboration, please type those in the chat box if you've got some examples that you can share on how your organization is collaborating with the community. And this spans beyond just hospitals, right? Distributors, suppliers, manufacturers. How are you guys collaborating within the communities that you reside? And the last question I want to pose verbally here and see if we've got any verbal responses would be, how are you managing the massive amounts of emails and communication and everything that's coming in? How are you managing that and vetting it to the appropriate individuals and communicating that to keep your frontline clinicians and caregivers up to date? Any examples of what folks are using to employ the massive amount of information that you're receiving? Would love to hear some examples within the next minute or so.
I've got 2 people, the first 2 to raise their hands. So Thomas Archer, your line's unmuted.
Good morning, everybody. Can you hear me okay?
Yep.
Yes.
So first, just an FYI, Health Trust we've reorganized our staff into work streams specifically focused around each aspect of this disease. with the sole goal of going out and finding alternate suppliers, touching base with contracted suppliers to make sure we got inventory chains. And the way that we're managing that internally is a number of email boxes. So if anyone in an organization is given a lead, there's an email box that they send that lead to, which then gets disseminated out to the teams to go out and research and pull everything together. Then that we're putting that back out to the membership through daily newsletters around COVID response. And we're creating a storehouse internally. So it goes to the vetting vendors, it goes to finding inventory levels, but we're doing that internally with dedicated email boxes, which are managed by a team who then triage it and send it out to the appropriate work teams. So I would urge everyone to touch base with your GPO, whether you're mine or not, or whoever's, because I know a lot of the other GPOs are also doing similar efforts, and they can really share as that source of information.
And that's a great point, Alan. Thank you for sharing that. You know, as we look at the resources we have available, GPOs absolutely are a strong ally in this as well. So thank you, Alan, for bringing that up. We had one more question, and then I think we'll have to end it at that because we're actually a minute over. So thank you for sticking with us. One more question, right, Melissa?
Yeah, we have Victor Suarez again on the line. So let me unmute you, Victor. Victor?
Yeah, I'm here. So there was a question regarding. There was a last discussion question. I was actually doing some work trying to redistribute some PPE on a spreadsheet, but yeah. But there was a question that I thought I could help with that somebody asked about 2 minutes ago, or there was a topic there. Could you guys refresh what that one of the last topics were?
Sure. So a couple of them that I asked for chat responses were, how are you calculating burn rate, and do you have any forecasting models? Mm-hmm. Correct.
So I can give you two things that we were using. So about 3 weeks ago, we had a clinical team combined with a public health team come up with a PPE calculator that would be done in a notional scenario of a medical treatment facility, worst case scenario of having COVID patients, and it was broken down by the various articles of PPE items per shift, per type of role, whether you were a nurse or you were a physician or you were some other type of staff. And so what we did was we had each of our medical treatment facilities kind of calculate what they had on days of supply in their stock. So not only in their rotational stock, but we also have our contingency stock at each site. And then we had them calculate based on that worst case scenario where they would be in days of supply. And then, as you can imagine, over the last 2 or 3 weeks, we've developed some further tools to kind of get after that, and reporting tools so that they can measure that burn rate based on worst case scenarios. But what we saw in practicality was that in the last probably 2 weeks, the majority of the consumption came from just normal daily healthcare delivery, not necessarily COVID patients, until the last maybe week or so. And so as the supply chain was kind of gunked up, if you will, in the last several weeks, they were really going through a lot of normal rotational PPE. And then there's a steep learning curve that probably occurred in the last week where we started seeing a lot more COVID positive patients into our clinics and our hospitals, and some of them have been admitted now across our system. And what we're seeing right now is that in the actual COVID patients, and we're just seeing this right now, that the consumption of PPE was actually in many cases higher, much higher than what we had projected when we coordinated this with the clinicians about 3 weeks ago in their calculator. So we're still trying to refine that based on trying to share lessons learned throughout the clinical channels, and then also embedding our our logisticians with our clinicians to get a better, more accurate process for refining the PPE calculator. And then yesterday, it was pushed out military system-wide. The CDC came out with the PPE calculator. So that's a spreadsheet that was put out by the CDC that maybe AHRMM can push out to its members. But it was pushed out, I think, 2 days ago by the CDC. And we're going to assess how that kind of fits in with what we're seeing right now and the steep learning curve that we're going through. But that's what I would say is what we're using right now is our original PPE calculator based on our clinical advisors, measuring that with our days of supply that we have, knowing we've shifted from normal consumption to COVID patients now and kind of a mixture of both. And then now we're going to try to look at the CDC calculator and see how we can incorporate that in our system if possible. And that's all I have. Over.
Thanks a lot, Victor. So I know that we've gone over 5 minutes. So thank you for those who are sticking around. I'm going to go ahead and wrap us up, and just building on quickly what Victor talked about. We do have the PPE calculator. AHRMM has that. As I understand it, the CDC spreadsheet is locked, but we do have the password. If you contact us and reach out to us at arm@aha.org, it's on the screen there. We're happy to share the calculator with you and to share the password so that you can unlock it if you do want to modify it for your organization. So with that, I want to thank everybody for joining us today. Thank you for the conversation we've had live. Thank you for your chat information. We'll leave the chat box open for another few minutes here, just for those of you who want to finish up your typing, to go ahead and do that. We will be compiling all of this information by the questions that were asked and the responses that were given via chat and verbal responses, and look to be getting that out to you sometime next week as a resource. I would also ask everybody, please, if you've got lessons learned or something that you want to share to the broader community, right? This is a learning community. We learn from one another. Send those to us at arm@aha.org. Thank you again for joining us today and for your continued hard work during these times. Really appreciate it. Stay well, everyone. Bye-bye.